when it's real.
Well, luckily for you, Melissa, we're live right now, but I can't find my lip gloss, and
Oh no.
Are we
This
actually
is an
live?
emergency.
but I
Do
did
you
find
like?
this large amethyst crystal in my travel bag right now.
Oh my!
So
Is
Oh
it the
my
one
God!
wait, did
Is
I
it
give you a
Ryan?
crystal? Wait, who
no,
gave you a crystal? Me or
Is every?
Melissa?
No, I think Ryan.
this is a third party. This is a third party.
Where's the one that I gave you?
It's in actually no, it's
Wow.
well. I
I'm
promise you, it's in
lost.
my bag because I believe in traveling with my crystals.
See?
It's one of these two.
Yeah.
It's the
I don't
purple
know.
Exactly.
one, isn't
I
it?
think it's the purple one because this one was all about my uterus, and you didn't feel comfortable
Yeah.
giving that one to me. Oh, Michael, are you sad that you're here? Welcome, Michael Westover. Big deal at Providence. Guy who talks about interoperability with us on the internet. Welcome. Welcome to the Health Tech Talk Show.
Thank you. Glad to be here.
Interoperability is so hot right now.
It's like
God,
so hot. Oh
Yeah.
my
The
It's the
last 4 days.
sexiest thing out there.
it really is.
Amazing.
God. Everybody
We're going to
wants.
talk about interoperability today, loyal fans. Welcome back to the Health Tech Talk Show. We are way more unhinged. Personally, I am way more unhinged than I previously was. Mentally, not that healthy, but we're going to make it work.
I love all these things.
I feel great about it. Okay,
Yep.
we're going to send Michael back while we comment on the news so that he is not indirectly associated with any comments we make that are untoward and fired. So we'll bring him back after we do that. See you in a second here. Yeah, and Melissa, how are you?
I'm
I love
good.
your
I'm doing
background.
great.
I don't know what's
I
It's
going
am.
on
good.
there.
I'm at a resort because it was my son's 16th birthday, and we went to go see Bruno Mars. I
Amazing.
yeah.
Amazing. Okay, we'll send you back too. I don't think you'll get fired because of
I mean,
circumstances.
I don't think you'll fire me.
Oh my God, Lisa. So we missed last
Oh my
week.
God. Oh my God. We missed so many weeks. And
I feel like people are here for us this week because we missed a bunch of weeks.
Paul, I have a job to do. I can't be on a no-fly list.
Yeah,
Please
we
don't
have
tell them.
no, but here's what happened. So I was flying somewhere. So Lisa had to do this Innovator launch. Look how official she looks. Great photo. These people all look
Oh,
extremely focused. I actually joined the launch yesterday. I thought it was quite good. Lisa, you sounded extremely professional.
thank
Um,
you.
yeah, more professional than you do on the talk show, and I feel like that
Thank
was
you. That is for sure true.
yeah. So we were cutting it close anyway because Lisa was like, my recording might go over. We had Leslie on standby. We were going to rant about small business, and then I had to go here and pretend that I'm the most important person alive. Which, to be fair, I pretend I'm very important every day, so this was not a stretch. But y'all, Newark is trash, and my flight was delayed by 3 hours, and we missed
Yeah, Paul,
time.
seriously, Paul, and everyone from the great state of New Jersey, including Melissa. What is going on?
Can you
What
fix your
is happening?
transportation systems,
Yeah,
y'all?
yeah,
Ah,
guys.
ah.
Newark, they literally they have dramatically cut back the number of flights for almost the rest of the year. They were just like, you know what? Newark can't handle it.
Yeah.
Sorry.
Newark is it's off the rails. It's off the rails.
Not
So
good.
anyway, so we missed that talk show. We're going to try to do a pop-up one with Commander Michael Banyas, who you all know. Exactly. I feel very confident that for a minute I
It's
was the
great.
most important person alive. But we got to do a pop-up show with Michael because they have like NIH is actually still doing the SBIR grants, and there's a program and there's a deadline that's like June 10th or June 11th or June 12th. This is what we're going to have him on the show to tell you about that. And we believe in small business over here at the Health Tech Talk Show. We are into it. So that's what's happening. Sorry we missed you. We got a lot going on. Like
We
this.
are we are in fact a very unsuccessful small business.
No, y'all, I would like to report that we have already paid enough this year to pay not only our QuickBooks subscription, our Gmail, Google Drive subscription, our website fees, as well as our overwhelmingly expensive media liability policy.
Amazing. Amazing.
Anyway, okay, so Lisa, we were going to talk about the CMSA STP RFI. There are 1 million analyses on the internet. What is yours?
There are. I mean, so this is interesting. It's very, very long. It's basically CMS saying, what are the barriers to better and more meaningful adoption of technology across all the things that CMS does, whether it's, CMS regulated payers or all of the ways and all the rules they build around providers and how they pay people and things like that, like all the operation of their programs. It's very wide ranging. It is extremely long. This is like that meme where like someone uses AI to summarize a huge thing and then someone uses AI to like read the summary because you're gonna want some processing help here. The 30-day comment period is rough. I agree. Catherine just noted that. But yeah, oops, sorry.
Oh, we did it at the same time. Wah, wah, wah.
I'm gonna do it.
Okay.
I'm gonna do it. Yeah, 30-day comment period is really rough, but I think just a reminder, you don't have to respond to everything, even if you want to. Getting back even just like the highlights of what you think about this, will very likely be helpful. And I think that these folks are listening. This is like the CMS technology leadership, the CMS technology advisors who are working on rolling stuff out and making updates, and they probably want to get moving on that. So they put a 30-day comment period in. There's never a good answer though, right? 60 days, 30 days, whatever, like there's never really enough time. Just try and
I say
get them some kind of
shorter,
response if you
yeah.
care.
Shorter
Whatever.
the better.
Yeah.
Let's
Yeah.
go hard. Yeah.
Yeah.
So I think Paul Wilder is listening to our show. I actually have a nod to his most recent LinkedIn comments. I actually like kind of am a fan of this approach. I really like how, at least my read is, it appears that they're trying to promote an ecosystem as opposed to kingmaker type solution to health tech and
Yes.
interoperability. Into it. But actually, so a couple things. So I did really like Paul's note about different apps in your phone. Sorry if you can hear my children. Their school was over yesterday. They're going to be here all summer, y'all. Yeah, Paul was like, I have 4 different calendar apps on my phone, and I just wanted to see which ones work the best. But like the information flowing into them is the same. And Lisa, I counted this week on a single day, we used all of these communication platforms to communicate with each other.
This is probably accurate.
I can't actually tell you what the difference in all of them was. Like, it's all the same stuff. And on Slack, we actually are on 2 different Slack channels together. So
this is also true.
All one day. So I kind of like, in general, like doing analogs is tricky, right? Because there's always someone who's going to say like, well, it's not the same thing. And it's usually some dude on the internet who's saying that. So but I do.
Yeah,
I do
I should just say, I actually, as you respond, here's my answer that I've been like my analogy I've been using since starting working at CMMI now almost a decade ago is don't write about your diabetic shoe factory model. Like when you are responding, don't be like, I have a solution. It is called Lisa's Technology Company, and it is the only answer possible to solve these problems. Like, please. And I say the diabetic shoe factory because people would put in these requests for CMMI payment models, and it'd be like, I own a diabetic shoe factory, and I think you should do a payment model just for my diabetic shoe factory. And it's like, no, like think a little bit bigger. Like they're not going to do a single solution just for your company. Like don't write that. Like you can write about the stuff you do, but don't say like the way to solve CMS's problem is to adopt my thing. Exactly, Brendan. And stop sending us Marco Polos while we are live on the internet.
I feel like he's proving a point
Dang.
or not paying attention. Although I will
Probably he is. It's
I did say mostly, yeah.
Emma. Correct. In this case, it's Brendan.
Yeah. Well, Paul said stuff too, but I will say, Catherine, who is a freaking lady boss, also commenting on this topic.
Right.
So, but I have a different analog for you guys because I feel like, how many times are we going to have to hear about the goddamn railroads? Like, how many times?
Yeah.
Railroads? I have a different one for y'all. One where there is a regulated product and the option of a regulated distribution channel or unregulated distribution channel, America. So here we are. I bring you the liquor store. So sorry about the beige got cut off there. So I've spent time in both of these states, a lot of time. I live in one of them. And in Utah, we have a regulated product, alcohol, and a regulated distribution channel. This is what the state liquor stores in Utah look like. And I will tell you, the selection and access is minimal. It is not great. People still are drunks and alcoholics. It's just a shittier experience overall. No one's happy. In Georgia, this is the liquor barn. Everybody loves the liquor barn. We have a lot of options. Our product is still regulated, but you can also buy it at the fucking racetrack down the street. You can go anywhere you want to get this regulated product. You get a license and all that, but there are lots of different distribution channels for it, and the experience is way better. And we're all still drinking the same alcohol, although you can get definitely higher shelf situations at the liquor barn. So I encourage you to consider this analog, and why I love the CMS RFI, which I'm absolutely reading into, that they want more of an ecosystem approach where we'll have a regulated product, which we obviously still do. Whatever. Shut up. Listen, do you want to talk about the goddamn railroads, Brandon? And we want to talk about liquor stores, which is a better story. Also, we're not talking about the banking system, y'all. I do not want to hear about the banking system. Anyway, this is the move. Let's have a lot of different distribution channels, a lot of different options for different people, and let's still like have some guardrails around patient data, because that is some crazy shit. Boom. And also, don't drink and drive.
Endless beer.
Maha.
Maha. You listen, everyone here, everyone knows that Lisa is a fan of vaccines. I like vaccines. I think they're great. I love not having polio. I love it. I love not having polio. I love not having whooping cough, you name it. So that aside, like, sure, let's talk about like the state of health of kids and other people in this country. And while we're doing that, we need to make sure we keep NIOSH, as you said before, Kat, extensively around, public health and safety and things like that, stuff getting in the air, in the water, risks, public health risks at work and on farms and whatever, hunting, you name it. But like, okay, sure, yeah, great. This is great. I agree. The state of health in this country is real bad. It's real bad for kids. All those things are true. Lead is also bad for kids, so we should do things to like make sure we get lead out of water and stuff like that too. But like, sure, the fundamental idea here, like, I'm with it.
I agree with the fundamental idea too.
Sure.
I think, some of the analyses on agriculture, right? Like it's there. We should do more there, but
Cool.
that wreck the global food supply. I appreciate that people thought about that, right? Like,
Yeah.
good.
Yeah. Yeah.
Um,
Yeah.
the wild thing is like we all know that these things are true, right? We know to eat better, we know to work out, we know all those things. Like, I mean, it is hard to avoid chemicals in foods when it's not totally identified what those chemicals are and what they do to you.
Yeah.
Yeah, I feel like this is like a common sense situation, and I know in 100 days we will have actual recommendations. So, like, it's hard to like argue with the things in here. And
Well, I mean, I think I can definitely argue with anything that will make it harder for kids to get vaccinated or for people to be free of vaccine preventable diseases. But that's my biggest argument, I would say. But
yeah,
other than that, like I want people and kids to be healthier in America for sure. Like that's in everywhere, but also in America, I suppose. And like yeah, food systems, safe streets, being able to be outside, schools that don't like warehouse kids inside all day. Like, those are all things that are important, right? Like, I think those are real things.
Brendan, I just want to say I'm not going to take away your right to microplastics.
Brendan wants more microplastics in his
I'm not
brain.
gonna do that.
It's
I
fine.
wouldn't do that too because I'm pro freedom. So yeah, so speaking of the vaccine argument, I don't feel like this hit that really directly in any way. At least this
A little
report.
bit, but not. It wasn't like a direct hit, right? But it's just I think it's very real to cause any sort of additional doubt that what's in vaccines today is safe. Like, notwithstanding anything in the past, but we got safe vaccines, and if we do things that make people think that they're not safe, then we definitely increase the amount of disease, and that sucks. Like,
Yeah.
oh well,
Speaking of all the vaccine stuff and
polio.
messaging, I will say, like, I actually heard a really good argument for being supportive of the second look or third look or 12th look at vaccines. This is like, Lisa, like, I feel like we retired from PR too soon because I heard this and I was like, ooh, that's really good. Like, I'm having a hard time arguing with that. And it was, if this is for the safety of our children, isn't it worth another look? And I was like, ooh, so good.
Sure.
Ooh. Right or
Whatever.
wrong. I mean, like,
As long as when they get great information, when people get great, like, scientifically valid information, that they are like, all right, cool, got it. Glad we took that second look. But I don't think that's going to be the outcome. That's my complaint. I agree. I want second looks. I want us to have high quality information and, all of that. You've heard me, everyone has heard me go on about that for a while, so I'll stop. But like, sure, great.
You're
Let's
having a
do
hard time
more.
arguing with it too. I know. That's what I'm saying. It was good. I was like, that is a good argument. That is some solid baller messaging that I wish I thought of myself for other things that I'm fighting for all the time. Like, um, not having
But
tech.
like also make sure your kid doesn't get exposure to lead and make sure they get some time outside in like clean air and water and like, if you're going to care about one thing, you should care about all the things.
Yeah, totally agree. 100%. So I'm looking forward to the 100-day recommendations that are coming out here. Freaking, and Melissa just coming in with a link where you can continue to pay our media liability
Oh,
insurance for us. That's what I'm talking about. Okay, moving on here. All right, then we get the mega bill. So the mega bill passed the House, as we all know. We had our man, the speaker. Apparently, he was wheeling and dealing until like 6 in the morning or something. I don't know, and he made it
they
happen.
didn't sleep very much at all, which is like very concerning for speaking of health. Like nobody in Congress slept for the last like 8 days, which is concerning.
Yeah,
Very concerning.
yeah. I mean, I'm sure most of their staffers haven't slept for longer, so we
Right,
got
right, right.
things, but I don't know.
Ooh.
But it looks like it's in the Senate, and the Senate is making its changes, and the Senate wants more cuts, is what the current move looks like. So, yeah, it's looking like now it's like 500 million. Or am I right? It's not the 800 number; it's 500 for cuts to Medicaid. Is what the Senate's going after, and a bunch of other stuff going on
And
to
there's just a bunch of random stuff. Like a lot of strays were caught in the process. Like the whole like last minute things to be like, it is now illegal to own an EV. Speaking of freedom, Kat, you are now an EV owner and you should be mad if they're going to
is
try
that
and
in there?
charge you more.
Jesus
Yes.
Christ. Well, is it illegal
Yes.
or do you have to pay more?
You're going to pay a lot more.
Why?
Well,
Why?
that's the trade-off, I guess. And, I'm just that's why now in my household we are rushing to get a new EV lease before the screws come down. We'll see how that goes.
Well, that's a bummer.
I think that kind of stuff is dumb.
I got that car
What?
because I don't go anywhere. So,
Yes, this is true.
oh, wah, 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 wah,
Yeah.
wah. Okay, well, we'll see what happens here. Sounds like the big man is calling a bunch of people to make some stuff happen. TBD, we don't know. Honestly, I have a hard time tracking all the stuff on the Hill because it's like, random nighttime deals, which I'm into in general for deal making, but I don't know what's going on.
Well, for me, I also think like this is a real test of like literacy for the general public, and it's reported so um just irresponsibly, like this is this, and everyone's like, oh, this law has passed. I'm like, that is not a law. Those are negotiating points in a long process of like passing a bill through the House, and everyone's like reporting on it like it's already done. I'm like, that's not the final. That's not the bit. That's not the law that was like passed. Like that's not it. There still is reconciliation between the two houses. Like it just, I get it. I understand that like reporters want to have something to write about and they want to follow what's the progress, but this isn't the final version, right? And people are reporting on it and believing it like it's something that's already like signed, sealed, delivered. I just
Uh,
that's annoying.
that is always frustrating.
Yeah,
But yeah, we'll see what happens. I don't know. Hopefully, we should get someone on here who knows stuff about the Hill. We should get like a real
yeah,
lobbyist. We're neither
totally
neither real news nor real lobbyists, so we're
true.
just two girls on the internet saying stuff. Okay, speaking of NIOSH, okay, this I'm bringing up because I just wanted to complain a little bit about this guy who's complaining on the internet about his agency being brought back to life. I would just like to complain. So, okay, they're saying like, whatever, NIOSH came back. Obviously, it was partially because of me, but mostly because of the senator in West Virginia. No big deal. But this guy, this was in Political like this afternoon or something. He says the programs that were brought back were the ones that have been in the media, the ones that have gotten the most attention, like the National Firefighter Cancer Registry. So to that I say, no fucking shit. What? Maybe you should work harder to make sure people know what the fuck you're doing, is what I say about that. I read this and I was like, this person is the worst. And you know what, Lisa? This person works at a union, which I don't like.
Wow. I feel like that's the only thing you pull out from it is
Yeah,
like
that's what
he's
I
in a
thought.
union.
That's
Wow,
what I pulled
wow.
up. No, that's not the only thing. The thing I pulled up was this guy
Listen,
complaining and
listen.
actually citing the solution and why his group, part of the agency came back, and not acknowledging that maybe he should do more of that as a union leader. So mad. Once again, guys, this is like, you just need, like, people need to know what the hell you do for a living. Like, it doesn't mean what you're doing isn't important. It means they don't know. So clearly this is being acknowledged here by an employee of this agency and local union affiliate. But like, I'll tell you what, Lisa, like I said, we retired from PR too soon.
That's right.
Too soon. Moving on. Oh yeah, most favorite nation. What do you think about this?
Sure. Let's see if it actually happens. I mean, if there's anybody who knows about making money, it is both PBMs and pharmaceutical companies. So Godspeed is what I would say. Because just imagine in your mind a balloon and you squeeze one end of the balloon and then the balloon gets bigger on this side. Whatever. Like that's just the money will even out. Like they'll raise prices elsewhere. They'll do some kind of it just this is one of those things where like I agree in con with the concept in general. Like, I do not think that the US should pay more than other countries for drugs, but I also know that we are like not starting from zero. These are very complex and sophisticated systems, and like, sure, then
Yeah.
they're going to raise prices elsewhere and keep prices high on us. I don't know. Like, it's not, it's really hard. Like, listen, like, price fixing in general, like price controls. Hey, this is me being a capitalist right here, Kat. Price controls are bad. Price controls are bad, and trying as a government to like the water bed effect. That's nice. That's a good one, Brendan. I like this one. The water bed effect. The like anytime any government tries to like put like parameters around prices or like fix prices, that tends to be bad. I don't think it's a good idea.
Like healthcare,
Yeah, it
like
sucks.
healthcare.
Yeah,
Yeah.
yeah, yeah.
Yeah, I'm also like anti-subsidy. So this is essentially like a global subsidy, right? The U.S. paying more for drugs is a global subsidy to, basically the whole world, everybody but us.
Yep.
But like the big argument, so this is like, healthcare is an artificial market. It's hard for me to just like advocate for the great free markets because it's just not a great free market.
It's not a free market. It's not.
It's not. It's like as we just said, like
Yeah.
totally everything's set by. I mean, most prices are set by Medicare, right? People follow along there. But the big argument that I've heard about this that I understand is that if the U.S. isn't subsidizing the innovation R&D, which is what we're doing by paying more, then like who becomes the best? And here's where I have a big problem, y'all. I love being the best. I think America is the best, and so it
I
really
know.
bothers me that we may no longer be the best if we don't
Well,
continue to pay big
I think
dollars.
that's happening as we speak, unfortunately, which is a huge bummer because I also like being the best.
Mm,
And I'm worried about us not being the best anymore if we don't have this massive, just like hotbed for innovation, whether it's, science, technology, innovation, entrepreneurship. Like that's what makes us the best, just to be totally clear.
yeah, it's one reason I'm bumming about all these grants too. I
Yeah.
actually am bummed about the grants. Like,
You can
yeah,
make improvements without getting rid of the whole system, and I think they do have to push back on the like extreme level of price, let's call it differential between the US and other countries. But like, I just like pharmaceutical companies and PBMs and others in this space like are very smart and know how to make money, and they will probably keep doing that. So I don't know if this will work.
hmm, hopefully we just don't become not the best anymore. But
Yeah.
anyway, but I understand why we're doing this. I just understand what some of the consequences might be, which I do not like. Hinge Health went public. Apparently, it went well, according to the internet.
Well, they like had that little moment where it was like, "Oh, are we going to go public?" And then they actually decided to do it in the
Yeah,
same month, right? So things improved enough in that period of time where they're like, "Okay." And then Omada is going to be, I guess, right behind them now that I
yeah,
mean, Hinge going out and having it be like not a total flop right away, probably made everybody at Omada very, very happy. Um, Hinge Health claims as do their competitors. Their mortal competitor, their mortal enemy, Sword Health. The drama between those two companies is a whole other hilarious story. Hinge Health claims that they are delivering care like fully with, AI and those kinds of solutions, and that it's really great and it's working really well. I think, as we all know, for everything health tech, like the reality is not always as rosy as painted. But I think if I hope they're successful in this, I hope it keeps going. The reality of AI implementation and care delivery is probably a little bit rockier than is being painted.
Yeah. Has anyone ever, do we know who on the internet right now watching our show has ever used Hinge Health?
Uh, we do know Matthew Holt has written a whole thing about it. Remember? Was it Hinge or Sword?
I don't remember, but his posts are very long.
He wrote a whole thing about this, and it was like a whole like
Well, what did he
explanation of his
say? What did
experience.
he
Hang
say?
on, hang on. I mean, Matthew Holt is probably not watching our show right now, but I'm gonna find.
Sometimes he
I got
does.
it for you.
He
I got
usually
it.
watches it late and then comments like a week
I
later
know.
when no
I
one cares
know.
anymore. So,
You didn't even pay attention. That's so sad.
well,
Wow.
listen, Lisa, there's a lot of stuff on the internet, and I don't have, I got stuff going on. Okay, who's ever used Omada? Anyone used Omada? Isn't that? I mean, that's you gotta have the diabetes to do that.
I
Lots of
don't
different.
have the diabetes yet, so no.
Yeah.
It's coming, I'm sure.
Well,
I'll be there soon enough.
well, Lisa, just like we're going to document our journey through menopause, I'm looking
That's
forward
right.
to documenting your type 2 diabetes.
That's right.
All right. Well, congratulations to these guys. What an accomplishment. Like, this is something everybody wants to do. Oh my gosh. Okay. Ashley Ashworth. Didn't this girl just get a new job that I saw on the internet?
Yeah, Ashley, have you announced your new job yet? Because I feel like you should tell us.
I don't know how we get her
Let's
on the
just see.
show through comments.
It's okay. I know maybe she announced it on the LinkedIn and I haven't seen
I
it
think
yet.
I think she did. I think she announced that she has a shiny new job.
Well, I
And
knew that. I
congratulations.
just don't know where.
Well, Lisa, I don't have time. Someone else, Melissa, can you please
She's
find?
at Oracle.
Oh,
She's
she's
at
a
Oracle. She's gonna be with maybe somebody else we know
congratulations,
soon.
Promised.
Congratulations. All
Like
right,
we
yeah.
heard from our one of our friends
Success story.
during HIMSS. Apparently, Oracle's new AI EHR is super sexy. So congratulations on that. Yeah, actually, I don't know. Like, type in the comments what you think, or maybe we'll have you on later because we can't. I don't know if you guys know this. We haven't repeated it in the last 12 seconds, but we are not we are financially inclined. We make enough money. We are not technologically inclined. We'll figure that out later. 23andMe got bought.
That's right. This is probably the best outcome for them and for us and all of our data. I don't know. I
Mm,
mean, I think they were tried so many different things, and they didn't work, and now they were bought by this biotech. So good for them. And fingers crossed that they do what they say they're going to do with customers' data. The
yeah,
end.
we'll see. But hopefully, you all deleted yours as you were told to do by Grace Cordovano. And
Yeah,
also,
that's right.
that's
That's
the reason
right.
I did it. Okay, Lisa, you sent me this text from this guy, and it looks like this. I saw this also on Health Tech Nerds, but I'm not good at details. But it looks like the entire premise for general medicine is just having straightforward pricing.
Yeah, so TJ is not just some guy. He was one of the
Oh,
founders of
yeah.
PillPack, and then it was bought by Amazon Pharmacy, and then he left probably in a cloud of smoke. He has great commentary if you don't follow him. Just on he a very he's been through it is all I can say. And so I think it's really hard to get a sense of general medicine from their like first like just looking at their site. You're like, okay, great, I can I know how much I'm gonna have to pay. Apparently it goes beyond that and there's more about the experience of being a patient consumer with general medicine. Like they definitely are like telemedicine first, but then they have a lot of integration throughout, and they really lean hard on like exactly what you're gonna have to pay at any point in time. So I don't know yet. I wouldn't count him out. I think that they did something really him and his co-founder did something really unique with PillPack and got lots of really real experience of trying to change the actual experience of patients and consumers in the space. He's not actually, he's just like their lead investor because I think he made 11 bajillion dollars in selling PillPack to Amazon, but I think he's pretty involved here. So I don't know, something to watch.
Yeah, that
I
seems
like transparency.
pretty great. I'm into
Yeah.
pricing transparency
Yeah.
also.
That's right.
Yeah, well, back to the CMS RFI because we got 1 minute till we have to bring on our real expert, who I feel like I don't actually know if he's going to agree with us or not on our recent bullshitting, but I'm excited about it. I'm excited about this RFI because I am pro ecosystem. I also think it focused a lot on patient access, which I'm like totally down with. As everybody here knows, if patient access was like the returns were mandated through TEFCA, I would have been freaking supportive. I would not have made Q hints aren't real t-shirts. I mean, maybe I would have, but you know,
I would have.
the feels would have been different for sure. And I wouldn't have spent the past several years thinking it's bullshit and campaigning as such. So I'm into that. Either way, I feel like the outcome here is going to be either ecosystem approach into it, patient access, and or both. Basically, this is like the only time in my life I'm ever going to win on both sides. This is it. This is it. I mean, unless someone comes in and just like they just decide to buy Palantir or something and say they're going to fix interoperability, that would, well, whatever. You know what? At that point, I'd be
Can't
like,
do it. Listen, like I mean, the only thing I've agreed with so far recently is like, yeah, ecosystem approach. Great.
yeah. Well, I think that's
Because there's not one solution.
Oh, Pooja, we got to have you back on because
There
I
is,
only read
yeah.
the things that people send me, and I actually, Pooja, I saw your post about this, and I very much intended to read it, and I did not. So, hey, y'all, there's also another RFI out. This one seems like super dramatic. DOJ and Treasury. What? Okay, well, we'll feature that later because none of us have read it, but I believe it's very important. Okay, all right. All right, what are we doing here? Michael, glad you didn't get fired by being on that segment. Welcome back.
Well, glad to be back. I mean, uterine crystals, unhinged hosts, like endless beer. Let's do this.
Yeah,
That's right. Wait, where's the endless beer? How do I get that?
well, I
Oh,
am
it
not.
was on the picture. Sorry. I was like,
Yeah.
where is it coming? Where is the endless beer?
Well, Lisa, I will say,
Yeah.
Melissa posted just in our Slack that apparently we were invited on a show called PT Pint, and it's a happy hour talk show, and we were invited to be on their show. So
That's amazing.
I don't know
Perfect.
if anything is mandatory or not, but Michael, will you please tell all of America what you do, what your role is, and what you're about, and then a fun fact.
Fun fact. All right. So I do bidirectional data exchange between payers and providers. So I work for a big healthcare system, and I work closely with big payers like Humana and United, and try to get them to exchange data with us and try to exchange data in return and see if we can solve value-based care and all those good things.
Is it so easy?
It's not easy. No, it is not.
He's like, it is not easy.
What's the worst part?
Oh my God.
Oh, what is the worst part? Like, I think the worst part is trying to convince people that it matters. It's such a fragmented healthcare system. You would think you'd be like, wait, this is the most fragmented healthcare system you can think of, right? Interoperability is the thing. Like, this is what we need to focus on if we're going to be successful. I'm like, yeah, maybe.
That is so sad. So is most of your job technical or is most of it soft skills, AKA negotiation?
Most of my job is negotiation. Most of my team is the technical skill. Yeah.
Wow. Oh my gosh. Okay. Well, soft skills for the win again is all I have to say about that.
Yeah.
But okay. So tell us.
You want an interesting fact?
Oh yeah. I'm sorry. I was just.
So Melissa told me that her son turned 16, and so they went to a concert and are traveling. It sounds amazing. My daughter turned 16 today, and we're going hiking.
Oh, that's very Pacific Northwesty of you.
Hopefully, she'll be fine.
And you live in Seattle.
I live in Southern Washington, so Portland. Okay. Yeah.
Okay.
Right by Keeler. Yeah, he's been commenting.
How do you feel about travel to the East Coast?
How do I feel about travel to the East Coast? I mean, I'm tired when I get there, but it's nice. I lived in Boston and Philly and Connecticut for 10 years. Yeah.
We were on a lively Marco Polo with Brendan Keeler earlier. I'm the only East Coaster, and I was commenting on how much I love how easy it is to travel DC. And they were like, we're deciding if we take the red eye or spend an entire day on an airplane.
Those are the two choices. You take a red eye and hate your life, or you spend the entire day on a plane and also hate your life. There's no good option.
Yeah,
really.
no good option. All right, Michael. So, I think we bumped into you on the internet here and there before we met you in real life, before we met you masked at a party. No big deal. Um, and I feel like we kind of agreed with you on your interoperability theory. So, tell our loyal fans, all at least 70,000 of them today, what is your theory on what's the best case scenario outcome for you?
Man, that's such a big topic. Like the best case scenario for data exchange, and what scope are we talking about here? Like
all of America,
provider, patient, everything.
The promised land.
The promised land. All right. So maybe I could just start with the thing that's on my mind today.
Please.
It's good to be bite-sized. Yeah.
I think we need to get data out of the EHRs. Like I'm going out on a limb on this, and it is amazing. It is difficult. The EHR Association came out and said, you know what, let's not do bulk data exchange. Maybe we could cut that out. I say we go the opposite and we make bulk data exchange work like at scale, not just for one patient and not just for a panel, but for huge populations, like for where you have value-based care, so that we can have innovation that happens outside of that connection to the EHR. Like we can just free it up so innovative companies like Innovacer can do stuff, like so that providers can do things that might be outside of the EHR. I mean, why not allow that to happen? Let patients pull stuff into the apps. I'd say that's one area where I feel like we could make a lot of progress.
So I have a question for you on that. Does the EHR need to exist? I'm not leading the witness. Do we need systems of record? Yes.
Does the EHR need to exist? All right. Well, a provider does need workflow, right? And there does need to be business logic. And there does need to be some data storage and the provider's ability to do the work.
Sure.
Does there need to be any system of record from the patient's perspective?
I mean, what does it even mean? Because if Providence has an EHR, or probably has many EHRs, but let's just pretend you have one EHR, haha. And exactly, so you have three, exactly. Yeah. Also, join our bulk fire Slack community. We are part of it. Yeah, we're bulking up there. Let's pretend you have one EHR. What does it matter to a patient? The patient has records all over the universe. They're in 50 EHRs, 100 EHRs.
I know.
What do I care?
Yes. We need someday we're going to actually take the leap and say, maybe it doesn't matter how amazing my app is at my health system or how amazing my payer app is. Like we just can't do it in one siloed organization. It's just another excuse to silo the data and cut folks off. The only way to really get this to work is to make it easy for the patients to get the patient's own data from wherever it resides. And people keep saying patients aren't accessing the data, so they don't care. That's not it. Patients want it. They would use it. It's just so hard. You try to log in and pull the data, and then your token expires halfway through your session, and you can log into your app, and then go through 4 more tiers of logins to get your data, or it's stuck in some PDF format. We can do better.
Right.
Yeah.
Right. I mean, I don't want anyone to think I'm coming for them. Right. Love you, EHRs. You're my friends. But so it's fine. But I think the future innovation piece is how do we move beyond that? Because it doesn't matter to a patient. And then it kind of also doesn't matter to a physician or a clinician or provider, because ultimately, as we know, the ideal world is that they are getting the data from wherever it is and it's being coordinated in the right way so they don't have to hunt through and dig through and click through a bazillion things, right? You don't care. Which physician wants an EHR? They just want the data in the system and they want it to work quickly and without a lot of extra effort. That's it.
Yeah. And I would say you could even look at it from a single health system like Providence. We just have Epic, but we're so big, we need 3 instances of Epic, which is wild to me, but that actually is a thing in today's day and age. So, but not everything that a provider does is through its EHR. We actually do some things that have nothing to do with EHR. We have value-based care connections and public stuff. And I mean, we have applications that aren't connected to the EHR at all. So we have network affiliates and all of it. So if we're trying to say that all of data exchange needs to happen through the HR, that just doesn't work even for the provider organization that is supposed to be working side by side with the HR. It doesn't make sense for many of us. Yeah.
One would say if you were innovation, you need a system of intelligence that connects to all your data sources and makes sense of them so you can do other cool stuff on top of it. That's the end of my advertisement.
Innovator.
All right. I'm into it. I'm into it. So I love that like you're on our team. Like it's nice when someone isn't and we get to get in a fight, but I'm like kind of into this. So yeah. What do you think of the CMS RFI? How would you as an independent human have responded
Okay.
to that?
CMS RFI. So I felt like I've been neglected for at least 6 months. Like I didn't know if anybody cared about interoperability in the government and if they're going to do anything, just like let it sit and die. So the fact that someone came out and said, Michael, like I would like to hear from you. I care what you're thinking right now.
Oh,
Like I that's meaningful to me. I also like that they're trying to get to what's going on in reality. Like, how do you feel about bulk fire? Just tell us. How do you feel about TEFCA? Like, give it to us straight. Is it helping? Information blocking. How can we make it work? Like, digital identity. Is it a good thing? Is it a hassle? Like, tell us what do we need to do. And I'm all for that. I also love the patient focus. There wasn't even when it was talking about business to business data exchange, it was all so that we can help the patient. It started with the patient, kind of ended there. I liked all of that.
So you loved it. I loved it too.
I mean, it felt like Posnack and like Ryan Howells kind of like influenced this a little bit. Like you could see their, their stamp on it, and I think there's just a lot of great stuff there. Maybe it's not perfect, but I like it.
so
Yeah.
how far are you? How many pages are you in your response so far? Like, what are we up to?
Are you kidding?
Or are you
I'm up
doing
to
a video? Are you
7.
doing a TikTok? You could do a video also.
I'm up to 7 pages on my response so far, and like half of it's going to need to get cut out because it's really Michael's feelings and not what is best for the company I work for. But I'm going through it. Yeah.
Amazing.
Yeah.
We could just take a snippet of the liquor store rant, and that could be my response. I'll be like, listen,
You could legitimately do that, Kat. You can send them a video as your response.
deregulation.
It's great.
Yeah.
Yeah.
Amazing. Yeah. Yeah. Yes.
Big part of this.
Oh wait, what?
Stop it. If
Yeah.
I put it up there, I'm taking it down. Kat, those are the rules.
Well, at least I thought I put it up there. We clicked it at the same time. Jesus Christ. Anyway, okay, whatever. Anyway, Michael. Okay. What else do you want to tell us?
What else do I want to tell you? I'm new. Like, what do the people need to hear?
You know what? You know what I actually want to know? What do you think about the Ryan Howells, Karen Alliance, patient identity? I mean, it's not all theirs, but like, what do you think about patient identity in general? Like,
all right. And I'm going to give you my bias because patient identity is a huge pain point for me that hurts patients because like we have 1.7 million lives or we're at risk with the payer, and the payer sends us data, and then we get data out of the EHR and we try to match, and we spend millions of dollars on this just trying to match the lives, and we miss stuff. So I've received telephone calls like, why we called someone who didn't have a visit at the hospital yesterday and told them that they did, and now they think their data's been stolen. So I feel like we have to live with this. And if we could figure out identity, like imagine a scenario where the patient's been gone through that IAL2, and we know this is Michael Westover on one side, and then the payer's done that too, and the data just flows right through, and like there's no ambiguity in it. I know this is, the long-term vision. So that's what would help me personally. But from a provider perspective, getting the infrastructure in place to manage that in every single clinic and to make it work is a lot. And there's some privacy concerns, and how do patients feel about taking the selfie and sharing the data. So I think there's some hurdles to overcome, but can we do better with identity? Is it absolutely important? Yes, especially because we don't have a national patient identifier. So
do you think I was talking to my mom's favorite talk show guest, Paul Wilder? Maybe you'll be the new one now that you're here. She watches the show.
Yeah.
I was talking to him about this, and I was like, don't you think like now is the time with this administration and the current political climate that we could just push through the national patient identifier, like finally? I recognize we would wipe out entire categories of the healthcare IT ecosystem by saying we wouldn't need like all these MPI companies or whatever, all these coalitions. They'd have to retire and say we made it happen. That would maybe be sad for some people, but yeah.
I mean, look at RevCycle. How much of RevCycle is trying to identify if that's Mike Westover, Michael Westover, the back and forth there? I mean, money, lives, patient care. value-based care, it touches, it's like one of those foundational things that we should have knocked out before we decided to jump to TEFCA. And say, like, we're
Yeah.
ready for the
Yeah.
national
Oh,
network, but
yeah.
we haven't
Ooh,
really
I
figured
like
out how
that.
to do identity.
Solid,
Uh,
Michael. That's a good one for us to think about. And I agree with Paul. Like, who cares? Already an infrastructure, whatever it looks like, for Medicare ID. You can just go and get one. You should be able to get one. And then that's your Medicare ID. Okay, great.
yeah,
Done. Like it's not that we already have it for a lot of people. Like, why is this a problem?
I know. And even some of the identity companies are thinking, if I establish Michael Westover at the provider and the payer, I'm not going to create a single identifier for that Michael Westover that they can then link. And I would love to get it to a place where we can actually make it we can have an integrated system. That would be nice.
Yeah. Oh,
It
wait.
is backwards day.
Yeah. I don't know. Is having an identifier communism? I don't know.
Only if you're insane, because genuinely everyone, like every other country, all of them from every single range, like has this thing. Also, by the way, I know this is like people are, oh, this is so horrible, but like most other countries, they like require you to register your address with the police. You have to have a photo ID on you at all times, your government ID, and your address registered with the police, like in countries that are not communist countries, just to be totally clear. It's very normal.
Yeah,
Americans are like, they just like don't want any possible, they both want like no oversight, and then also we all want no oversight, and then also we want like full price controls. Which one is it? You can't have both those things at the same time. They're
yeah.
totally on the other end of the spectrum. Let's just get a Medicare ID, whatever.
I know this is how many times has the NPI initiative failed? Like more than once, I
Oh
know.
my
Um,
goodness.
but
A lot.
it is a bummer because we have social security numbers. Like when we're freaking born, there's if you're on Medicaid, you have a Medicaid ID, and then you get a Medicare ID. And
Mhm.
also, like the government has everything on me. I have global entry. I've got pre-check. I've got clear. I've got the
Same.
digital ID thing, which I think anyone gets now because now the whole world's on
Yep.
Real ID. Listen, yeah, I mean, I don't know if that's to Brendan's point. I don't know if that's like anti-freedom. Maybe it is. Maybe I'm anti-freedom on identification.
But
Well,
Michael, can you think of like how much money it would save even just one large health system starting with a P? Like if you didn't like I mean just like give us like a ballpark, like bigger than a bread box, whatever. Like a lot of money would be saved. You would not have to spend on some of
well,
these matching activities.
I mean, it depends on how hard it is to implement it. I don't know how to get
Sure.
all the devices in place and how much you're going to pay Clear and ID.me and all the little other entities that are going to get excited about this. But I mean, it's absolute. I mean, it's millions at least.
Sure.
Yeah,
Oh,
tens of
where's
millions easily for a health system like Providence. Yeah.
I did hear, Anish invited me to this thing a while ago, a couple of weeks ago, more than a couple maybe. And we did hear from someone who is relatively official that they're considering using like mobile driver's license type stuff
Yeah.
as a way to solve this problem. And I was like, I mean, yeah, let's freaking go for it.
I,
Whatever.
I don't think we've really come to terms with this whole tension between like patient autonomy, like privacy, consent, and then the desire for interoperability. I feel like whenever we talk about them, we say patient consent is good, and I actually believe that patients should be able to consent. Patient privacy is good. We shouldn't share data they don't want to. But in a world with value-based care, just imagine where 30% of the patients say, no, I'm not going to share that data. And actually it's the most, or I'm not going to share the most important data for patient care. There's actually some very difficult, I think, decisions things we need to come to terms with. And some things like value-based care and consent and privacy just don't work that well together. I think we honestly haven't worked through that as a nation.
That's
Like I'm all for that, by the way. Yeah.
yeah.
I don't know what the right answer is here, Michael, right? I think there's obviously it's going to be some kind of balance here, but I do think that I hear the people here in the chat. Paul, I understand, like I'm not excited about my data being passed around. Guess what, Paul? Your data is already being passed around, and
Yeah.
probably more than necessary because there's such, like unreliable matching. And I just and then also just like there's our data just flies around the universe because we have this weird, very like weirdly restrictive construct for data privacy and protection called HIPAA. And then we, as you well know, and then we have nothing else for everything else. And the data can go wherever you want at any point in time. So it's just like
Yeah.
it's more than even a legal fiction. It's just a fiction. It's a fiction. And
Yeah.
so until the US gets, as we all know, Lisa wants comprehensive data privacy and protection law, I can keep dreaming about that. But in the meantime, the data is everywhere. The data are everywhere. They are all over. They are in
Yeah.
every corner. You can buy it for cheap. You could steal it for cheap, whatever. Like our
Sure.
data are already everywhere.
That's been a downside of basically everything being in limbo for the last 6 months. Is things that are not working are still not working, still not protected, and we're not getting the innovation. It's just the worst of all worlds. Yeah.
It
Yeah.
is. I agree.
Oh my goodness. So, just because it is a big question, right? So you're saying like, patient-centered stuff, like not I know Lisa was not trying to lead you, and it sounds like you're just aligned on that. Like, how do we?
No, I have the solution. Okay, or a solution. All right, how about this? What if we say, if you want to share your data, you can participate in a value-based care contract. But if you're not willing to, you're out. Like, you might not get the benefits of that thing. I would love to get to a place where patients can make decisions about what they want to do and what programs they want to participate in. The truth is that their patients participate in programs and they have no idea.
Right.
Yeah.
Money and data is changing hands behind their backs and they have no way to even see it. I sent a letter to just because I was curious, to my healthcare provider, and I said, are you participating in any national networks? And do I have the ability to say where I can share my data and not? And the response was, we cannot restrict those data flows. And so we're going to say no to any request about that. Like, if we don't have the ability to restrict the data flow, we're not going to do that.
Wow.
That just feels icky. Yeah.
That's depressing. It's just depressing that we're so let's talk about what they can do. And I assume what's in your 7 pages so far of your feelings about this
Oh yeah.
response is like, like what do we, let's spitball a little bit though. Like, what do we think that CMS can actually do, or even just HHS writ large, or the government writ large? Like, what can or what should they do?
I mean, when it comes to interoperability, there's so many fronts they could tackle. I think that they should go after, at least support the foundations that are required for care, right? I mean, there's some things that could actually help. HIPAA has issues. I mean, you go after that. You could go after patient directory, like provider directory, endpoint directory for how you would like to exchange data. That's great. Supporting data standards for certain things is really, really helpful for me. I get hundreds of strange data from all these different payers, and going after those data standards could help. What else could we go after?
Ron from De facto Health had a hilarious post yesterday being like, hello, US government, CMS and the VA both released RFIs about provider directories. Here are my suggestions for you two working together on provider directories, which I thought was like a hilarious and well-made point. We'll link to it in our thing. It was good because that's usually where I'm like, hello, US government, please meet other person in the government who is responsible for overseeing this one little area. Why don't you work together and you could solve these things together? Shocking.
Yeah, I would love to see some innovation around contracts too. I feel like there's the trust network where everybody trusts each other equally, and I feel like that might work in a clinical situation where it's one provider connecting to another provider. But when you start adding in vendors and legal firms and sub-participants, it's so complicated. I think I'd love to see some innovation at the state or regional level around, like, what if we had different levels of trust and experiment with some scalable contracts that had certain tiers? Like that could be really, really helpful, especially around prior auth, where I don't want to do 100 different contracts with different payers and negotiate all those.
That's super interesting. I mean, I like what you're saying about, you're saying put the control in the patient's hands. They get to decide what they're going to do by, they might save money by going on a certain different kind of plan.
Yes.
Is there a way to incentivize industry? Like, what would you do if you had to incentivize payers and providers to collaborate?
All right. So can I give you the foundational issue that I cannot solve is who pays for healthcare? Like, who decides who receives healthcare and who receives healthcare are all different people, right? So, and that just creates problems everywhere. But one of the main problems is the money is not flowing from the patient. The patient actually only pays 10% of the healthcare. So that means that it's hard to get funding for those things that are patient-centric, right? Because they're like, how do we get funding? How do we innovate in this space? So, I mean, I would love to go back to the beginning of that and like restructure how health insurance is. I mean, that's wild out of it. out of the box stuff. What do we do to incentivize to patients to put them at the center? I think some of the stuff we do about saying patients can get access to the data for free. I don't think we should be charging a lot. I would love it to approach zero for what it takes for patients to get data. It needs to be standardized. So if there are 10 different standards that patients have to pull data across and innovators have to standard, I mean, that's painful. So if we can put the patient at the center and say, you have to be able to give up that data to their vendor or to the patient directly using data standard, USCDI plus, and then expand that scope, I'm all for that. I also love B to C to B. I mean, that where it's not necessarily a business talking to a business, but the business gives the data to the customer and then the customer provides the data to another business. I think that is the way that I see the world going. And I see the expenses that the businesses are going to be charging each other over time. That's going to be a hassle, and the contracting is going to be tough. And I think at a certain point, it's going to switch to, let's go through the patient. The patient will just agree. We'll get whatever we need, and then we'll send it. And it'll be the cleanest way to do things. And I like
But
that.
Michael, one more thing on that. Talk a little bit more about the fees that you experience as a customer, as Providence as a customer, when you want to use the data from your systems of record to do other stuff,
Yeah.
population health, other applications. Is there anything you want to say on that and how, like, what else we can improve there? Is it just the
Yeah.
standardization or is it also the fees?
All right. So when it comes to getting data from our system of record, maybe before we get can I talk about something that really bugs me about getting data?
Absolutely.
All right. So I found out last week that we have a vendor that's taking care of patients in the post-acute setting, and it's a great product. It's really helping, and we're reducing the cost of stay, and patients are happier. It's great. We're helping the patient experience, and we're cutting costs. It's great. But I asked them, "Are you paying to get access to these patients' data in other EHRs?" And they're like, "Yes, we are. It's a huge dollar amount." And I'm like, "Well,
Yes.
how much of that are you passing to the provider?" And they're like, "It's a big dollar. Why don't I send it to you?" And I mean, there are all these like hidden costs of how to get access to patient data that I don't see
Yes.
as a net good.
Yes.
Um,
Yes.
When it comes to getting data out of our own systems, I mean, the non-standard data is an issue, but I think that what happened is when we said there is a bulk fire, we need to get the data out of the EHRs in bulk, and to become a certified EHR, you have to do that. So the EHR said, sure, we'll do it. But there's no financial incentive for them to do that. And then we, as clients of the EHR, go to them and we say, we actually want you to make this work. Like, not just check the box, but work. And the response is, well, there's no funding for it because it's been mandated that we have to comply. So you're in this weird space of it's a mandated thing that doesn't really scale.
An unfunded mandate, so to speak.
Yeah, exactly. So what really needs to happen is that data needs to be spun out to a separate server, and it needs to be just looked at carefully, and you could make it really efficient and fast, and we could pull data out of those systems at scale in using standards. But that's not how it works. What happens is the data is available, but you can only pull it for like 2 patients. You have to wait around for a long time. I guess not the population as it was designed. So I feel like there are these things, these practical gaps that we really need to get past if we want to be able to innovate outside of the HRs.
Yeah.
Perfect. My hope is that we can submit this clip to CMS and just call it a day.
I think they're gonna like the eagle in the corner.
They're gonna like the eagle too. But honestly, like those are the points, Michael. Like those are sticking points that affect, as noted in the chat by our friend Brendan, the faint sound of 1,000 patient advocates shouting at once, like that affects patients, right? And we agree there's this fundamental thing where like B to C to B makes sense. Again, we're centering around the patient and the caregiver's right to access and use those data and direct it where they want to go. They should never be stopped from doing that, and it should not cost any money. Like, I feel strong about that. But then also there's this thing where providers, a system, or individuals who are actually delivering care are experiencing multiple types of barriers to use and access their own data, or they're taking on a big extra cost of getting data they need. And those things just can't happen over time, in my opinion. So that's my stump speech. That is my personal stump speech, I would say. I'm just drafting off of you because I agree with you on this one, Michael.
Is there anything you don't agree with us on?
Oh yeah, probably a lot.
Sorry.
We have bad ideas too.
Our
Yes,
language.
absolutely. Nothing's coming to mind, but yes, 100%. Yes.
We have terrible ideas sometimes, and we say
Sometimes.
stupid things also.
Yeah.
But you know,
Often wrong,
strong
never in
opinion, strong opinions loosely held. That's
That's
me.
how I feel. That's exactly how I feel about all this.
doubt. Love it. Love it. All right. Well, y'all, you have not too many days left to submit your TikTok clip to the federal government,
That's right.
and or traditional comment letter. You can find Michael on the internet, and where else?
The internet. That's all I have.
Yeah, he's
And that's it.
I think Brendan was like, he's my neighbor. So also, if you're Brendan's neighbor, then you're also Michael's neighbor.
Yep.
Great.
fantastic. Love it. Well, thank you for joining us. Anything else you'd like to tell our millions of loyal fans?
I would like to tell you that you are proof that you can say basically anything and still have a job. Yeah, I love it.
Don't tempt
Giving the world
fate.
confidence.
Don't tempt
Thank
fate.
you.
Like I said, often wrong, never in doubt.
Often wrong, never in doubt. That's Kat. Thank you, Michael, for being a strong voice here. We certainly appreciate it, and we will always encourage you and put you back on the stage whenever you want to say real things to your audience. And maybe hold on to your job. We'll see. TBD.
Yeah. Also, really great that you are someone who actually has to make interoperability work as opposed to random people on the internet who may or may not
That's
be.
right.
Yeah.
That's me.
All right. Thanks, y'all. Happy Memorial Day weekend. Fun fact, Memorial Day and 4th of July are the only days that I don't work. So that's great.
Michael! Love you.
Fan of Westover says bye as well.
All right.
All right. Bye, everybody. See you later.